my brother calls and says he's gonna commit suicide and he's at like now. What do I say? I mean, so far he's still alive and that was the last time it was 3 weeks in ICU.
Why was in the ICU?
Oh, because he took everything in his medicine cabinet and tried to drown us.
You don't need it that loud. I know you don't.
Okay.
I'm leaving, but I still I could hear it through the damn door.
Thanks for me.
I swear to God, is about people who have just become adults, it seems, have a tendency, or I've known a few are person do that I take in their life, and one recently is striking. Yes, and you're going to talk about that. That's something else.
What's that line? What age do you do that on? Yeah.
20, around 20.
Did somebody have a drummer? Did somebody else draw that line in the darker
Yes,
color
I
than
did.
orange?
That's my line.
Yeah, but I said in a darker color than orange.
Is there
Red to black didn't work.
Okay.
It's okay the way it is. Okay, those are some good questions. Any other questions before I start that you would like me to address if I can? Go ahead.
I think it's really hard to address this. How do you pick up warning signals from people that are contemplating suicide, and how do you know how serious they are in their suicide? That's
So that actually leads right into what I wanted to start with. When I was a psychiatric resident many years ago in Seattle, Washington, I was assigned for 3 months to the consultation liaison service at Harborview Hospital, which is kind of like the county hospital, like University Hospital. And one of our jobs on the consultation liaison service was to evaluate people who've been hospitalized for suicide attempts. And there were 2 attendings or 2 supervisors that I worked with in that regard. And I want to contrast these 2 gentlemen because they represent to me, in one case, how not to do psychiatry, and in the other case, how to do it. The first guy, and I can't remember his name, but he introduced us to the term alexithymia, which meant that you can't read moods. Alex meaning can't read, thymia meaning mood. And I remember he would come in and he would say to the patient, "So what happened?" And they would say, "Well, I tried to kill myself, but I didn't really mean it, and I'm okay now." He said, "Good." Not very impressive. And the most impressive thing that I remember about him is we walked in, and one of the patients that he was interviewing started crying, and he ran into the hallway and called to the nurse to bring IM imipramine, an antidepressant. The other fellow was a guy named Carl Fellner, who had trained in Wisconsin, and he would come in and he would actually sit down at the bedside and he would say, "I'd like to talk to you about what happened." And the person would often say, "Well, I tried to kill myself, but it was a mistake. I don't really mean it." And he said, "Well, from looking at your chart, you took a fairly serious effort at it. You're still alive, but I really want to know more about it." And he would sit back, and more often than not, the patient would just voluntarily start talking and sharing a lot of their story. And he would listen and he would ask questions about what they said and pursue it. And I already knew what he was demonstrating, but I learned it in spades by being able to contrast it between these two. Because to be a good psychotherapist, to be a good evaluator, to be a good psychiatrist, you need to be able to listen and talk, ask questions, and follow up. You need the details. And one of the best ways to deal with any problem is to know as much as you can about what's going on from the person as best they understand. Because as you listen to their story, you get some insight into how well they're understanding what's happening with them. And that's an important part, especially when it comes to developing a treatment plan. Because whatever kind of treatment plan you develop, you want to be able to work with the patient or the person that's sitting in front of you to come up with a plan that they can agree on. Now, suicide and depression often go together, but I want to make it very clear that there are many patients who commit suicide who aren't depressed. And there are many patients who are who are depressed, who never think about committing suicide. But there is a correlation in depression as a significant contributor to people getting to the point where they decide that they should take their life, or they should at least make an attempt at taking their life. And as a psychiatrist, when you sit down with somebody, I'm going to talk about depression first and suicide second. When you sit down with somebody who's got either of these problems, you want to sit down, and you want to take the time. You want to dedicate enough time so you can really get a good and meaningful history. And then you want to start thinking as much as possible with the patient about what kind of action you want to move forward to. All depressions don't require antidepressant. I was the rare psychiatrist out there that didn't immediately write a prescription. In fact, I had several patients who, after seeing them several times, would say, "Doc, don't you think I need an antidepressant?" And I would sit back and say, "You do." But I was so busy talking to them about their life and how they felt and where they were coming from that I would sometimes not immediately prescribe medication. That's getting harder to find these days. As more and more psychiatrists are working according to what they call a medical model, where the doctor listens and then prescribes. And that's not my model of medicine, and it's not one that I ever really aspired to, because I really appreciated talking with people and learning as much as I could. But when you're talking to somebody about depression, one of the very first things you want to do is begin to get a sense of how severe a problem is this. Because depression is a word that's used by all of us in some context, probably at some point in their life. And it runs all the way from people who have a situation that they're living in that's making them somewhat feel down, to a personality pattern that leads them to depression, to what we call a major mental illness, a major thought or affective disorder. And interestingly, when you have major affective disorder, that's one of the most important things to not miss, is it's the disease of the affect, of the mood, but it's also a disease of the thought. Because when you meet people who are very severely depressed, sometimes you can say something to them like, "It's really good to see you today." And they can turn into that into something that makes them feel depressed. You know, and how they do that is part of their thought disorder. That's part of their affective disorder. So you want to get a sense of how strongly and severely the disorder is there, how long it's been with somebody for how long, and how severely, and what has happened to them in the past when they've had episodes, how long the episodes have lasted. And if it's, on the other hand, a sort of situational problem, just discussing what situation they're in might be enough to handle it. It might not require medication. It might just be, let's sort of sort out how you're going to handle this girl breaking up with you, or this problem you're having in school or at work. And So what I'm really saying, and this is an answer to your question, Grady, is if you see something, one of the most important things is to provide a context where you and that person can talk and you can inquire and they can hopefully feel more comfortable in answering your questions. And then before you sit down to do that, you want to have in your own mind, what kinds of resources can I refer this person to? A lot of companies have employee assistance programs. And those people are supposed to be the people who the boss refers the person they're worried about to. And that person is also supposed to have expertise in how to sort out what's going on and a list of resources to refer to. And if it's a good employee assistance person, they will follow up and make sure that the person has followed up and gone to see that person. Or if they haven't gone, or if they did go and decided not to go back, why not? So that the follow through. Because one of the most important things in delivering psychiatric help or emotional psychiatric help is follow through. You want to be persistent. I cannot tell you the number of patients that were referred to me who were having all sorts of problems. And because I decided to see them on a regular basis, they got better. I remember one woman who was a nurse. She had bipolar affective disorder and post-traumatic stress disorder, very serious. And her insurance covered her seeing a psychiatrist once a week, once a month for 15 minutes. And she and I agreed that she would see me, and we figured out an amount that she could afford so we could talk on a more in-depth basis, because just from her presenting data, I knew this was a situation that required in-depth conversation and discussion. It wasn't going to go away in 15 minutes. It wasn't going to be taken care of in 15 minutes. And she had been hospitalized every month for the previous 6 or 7 months. And after seeing me 3 or 4 times, she was hospitalized once more, and then she was never hospitalized again. Mainly because she had someone she could talk to and relate to, who knew what he was doing and who could proceed in talking about all of the issues that she brought to me. And that brings up, that her case brings up the fact that a lot of times when people have a depression or a suicidal, they also have a dual diagnosis. They might have anxiety, they might have substance abuse problems, they might have any number of other situations that are going on. And you have to get that full picture if you're going to effectively treat somebody. So that's why the discussion and the talking and the intake is so important. One of the things that I wanted to talk about today, in addition to depression and suicide, is the difference between men and women. And this graph that is up here on the board that the people on Zoom can't see, because I put it in the wrong place. But let me explain. These are ages, so 10 to 14, 15 to 24. So if those of you who are listening from home, just imagine that we have different ages along the x-axis or along the lower axis. And when you look at this, the bottom curve is the number of suicides per 100,000 people in women. And since those of you who are on Zoom can't see it, essentially the women start out at 2 or 3% at the earliest age and get up to 8 or 9%, or not 9%, but 8 or 9 out of 100,000 in middle age and taper off near the end of their lives. Whereas, yes, these are suicides out of 100,000. So here in men, at the youngest age, they start at 4 or 5%. And I am curious about that because I've never dealt with children that much, but I'm sure that they must commit suicide at small rates. But 4 out of 100,000 is not a high rate. In adolescence, it goes up, and in mid-age, it goes up, and then it starts to taper down from about 30 per 100,000 to, at 65 or 74, that in that age group, to probably 20, 25 per 100,000. And then as people get older, men get older, their suicide rates go up. So you can see there's a very different pattern. And that's a question. Why would men and women have different patterns? And one of the most interesting things about this is that when I'm going to talk
I don't like it. Women drive men crazy.
I
You don't laugh, Ralph.
disagree, John. I think that men have a lot of friends at work when they're young, and when they're old, they don't have any more friends. Women lump on their friends. We do women's trips and have a blast when we're young, when we're older. That's what I think, and I think it has to do with friendship. I think men don't have friends when they're old. They had them at work and then they retired and then no more friends. That's the pattern I see.
that may be a factor for some men. I agree. I think that's really not for John, not for me, and not for some others. But one of the interesting things I was reading this article, and they interviewed 17,000 students in 31 different states in the United States, and they asked them to respond to about 100 questions regarding their mental health, their suicidal thoughts and behaviors, their sexual behavior, substance use, and experiences of violence. And this was a study that was done from 2011 to 2021. And there was persistent sadness and hopelessness over that period of time, went from 21 to 29% in boys, and went from 36 to 57% in girls. And you notice this is 2011 to 2021. The study that I was reading didn't say when that jump happened, but already COVID had happened, and we know that COVID affected mental health significantly. So part of that leap was certainly due to COVID.
Was there an age group on this or?
No, just there were younger people. On deeper investigation, the gap was not as wide as the data makes it appear between men and women. And part of the reason for that is because girls are more likely to internalize feelings while boys externalize theirs. Girls may cry when feeling badly, whereas boys are more likely to act irritated or to lash out. And boys are more likely to engage in risky, impulsive, and even violent acts. And one of the other studies that I looked at was a study in Sweden, and this was back a while, where in the 1960s and 70s, there was a epidemic of suicide and depression. So they did a program where they trained doctors on how to deal with suicide and depression. And the suicide rate dropped from 20 out of 100,000 to 7. But on a subsequent deeper analysis, it showed that the decline was primarily in women, whose suicide rates went from 11 per 100,000 to 2 per 100,000. The boys in the study, or the men in the study, went from 16 to 15. There wasn't much. And they explained this by saying men were much less likely to seek help, more likely to have doctors ignore their depression. Men with depression did not present with typical depressive symptoms, such as sadness. They are often hostile, impulsive, and aggressive. And subsequently, various research groups have developed questionnaires that try to get at nail symptoms of depression. More effectively. And in one of the studies that I thought was really interesting, they used a questionnaire like that, and they found that if I can find where I put it. Yeah, there it is. And this was a study from Canada for 1,000 men, and found that 8% of the men met traditional depression diagnosis on one of the scales that was used traditionally for men and women, 8%. 12% met criteria on the regular scale and on the one that was developed for men only. And 18% met the criteria that had been adjusted only for men. Showing that having a questionnaire that covers what's more typical of men is really important in terms of trying to make the diagnosis. And this becomes really important because one of the things that's so permanently part of our culture right now is guns. Because for every 10% increase in household gun ownership, suicide rates in boys go up 27%, 7 times more likely to kill themselves with a gun than girls are. So that's another reason why you don't have higher suicide rates, because a gun is a very effective way of killing yourself. Whereas an overdose or slitting your wrists is a less effective way of killing yourself. You have to really be more afraid to do more damage. And women often have skills that allow them to deal with their depression more than men
I
do.
was gonna say, a lot of this, I think men would be less inclined to discuss their emotional anything, you know, which psychiatrists do. That's kind of what you think. We just have to not want to expose that word.
Yeah, and we're also socialized to be tough.
Right.
And that means not show your feelings, not talk with somebody about it. And one of the other things that's interesting in the current era is the effect of social media on some of this. And people have made they've done a lot of research with women whose self-esteem and body image are impacted negatively by social media. But with boys and young men, one of the most important things to do more research about with social media is to look at how it affects their self-concept. And if they get into a place where they are less likely to share their feelings, where they need to look tougher, feel stronger, you have to take a different approach. And that may be something that happens on social media. I'm just so grateful that my children didn't grow up when social media was about. Because I know attentive parents, my son has a 12-year-old daughter, and he and his wife are both attentive to what their daughter is doing on social media, but I have no idea how to be attentive enough to know everything that's going on. It's difficult.
My kids are 35. Right at the beginning of it, they broke it in. It was interesting to see using what to do.
And when depression is part of, when suicide is part of depression, or a function of depression, that's a signal to any clinician or to a family member. This is something that deserves to be looked into. But when suicide is not so much a function of depression, but more a function of impulsiveness, like you see in men, then it's harder to kind of, grab it, see it. And one of the saddest things in my work as a psychiatrist was people who I knew well, who I was talking with on a regular basis. And the suicide would seem like it would, and this was mostly in men, come out of the blue. It was not something that they were talking about very comfortably or willingly, or maybe even feeling, but it was something that happened through their consciousness and then we would happen. And if they had a very impactful way of attempting suicide, they would be unfortunately successful.
Ryan, is any of this data correlated to children? I mean, there's also an argument. What's that? Children.
Tell me a little bit more what you're asking.
Well, I'm wondering if in any of this data, if there was a person responsible for small children. One children. different.
I wish that you're correct about that. I'm not familiar with the study that specifically looked at it, but I think that makes a lot of sense.
Lane, can you repeat the question for us remote people? Because we can hear you on your microphone, but we can't hear the people around the table. So if you could repeat their question, that would help us.
You want to repeat your question?
Sure, the question was what in the data, was there any connection to whether or not children were present? My thesis was the gender difference may be because of the difference in connection. Women.
Oh, okay.
Children.
And I was saying that I wasn't familiar with a study in that regard, but that it made sense to me that that would be the case. Because often, for better or for worse, women are more involved with raising children and more feeling connected to them. That doesn't mean that some of those women who love their children dearly don't commit suicide. But it may be a reason for why there's a difference in the rate.
I've heard, and I don't know if it's true, that if a family member or a parent commits suicide, you and the next generation are more apt to consider suicide as an option, as a barrier, instead of the taboo has been broken. I've had a college roommate's father commit suicide, and then their brother's marriage fell apart. He committed suicide. One of my friend's brothers committed suicide. She called up and she was trying to figure out how she was needed to die. She children wouldn't know, and it was this whole thing. And I was immediately 2,000 miles away. I was calling, trying to get her help. And I said, you know, when brothers commit suicide, I have to take this seriously. And then she's so mad because she's embarrassed. I called her children. And of course, they didn't want things. She felt a lot better. You know, you really, I felt like I was in another level of somebody said something, knowing this history that I couldn't sit on it for a day.
Could you all hear that? No? What she's talking about is if you've had a family member who's committed suicide, does it make you more likely, are members of that same family more likely to, because essentially a threshold has been crossed by somebody that you know? And the answer is yes. And she gave 3 or 4 examples of that. And including a friend of hers who called her from across the country, saying she was going to die, she wanted to die, and she actually called her children and intervened in her life, and it made a positive difference, which was of you to do.
So it's a genetic component?
Well, there's a genetic component that is associated with the disorder, with suicide, with bipolar disorder, both of which are likely to cause suicide. But it's also somebody in your family has essentially given you the example, then it makes it easier for you to go ahead and take action yourself. And I remember I had a patient, God bless her, whose mother had committed suicide, whose younger brother had committed suicide. She survived both of those. And then when she turned 21, her father committed suicide. And how she survived was by just getting very addicted to alcohol. And then years later, when I was seeing her, she had another brother who was a mental health professional who seemed really healthy, who committed suicide. And that was really hard for her, but she had survived so many suicides by then. She was a professional. and she had already made a decision, you know, especially as she'd gotten sober over the alcohol, because that's why she had originally come to see me, because of her alcohol. And she stuck with it. She did a lot, and she was. I'm sure that the family history was not just a genetic factor in her case. I'm sure it was a genetic factor, but it was also that somebody had already crossed that line and set an example that made it easier for the person to follow. So
That
that's,
becomes an acceptable way to solve a problem.
That's the big impact on younger families.
how would dignity affect younger families?
And I realized I had walked over. Let me leave this.
An accident, the dog had an accident, and then she walked on the carpet.
Stop. Joyce,
Joyce?
could you repeat that? Or is she talking to her husband?
Or mute it.
Joyce, you're unmuted. You're unmuted, Joyce.
I think
Go ahead.
Well, death with dignity, you decide you want to die, and if you take medicine for it or somebody assists you in this, and you're removing that whole concept that you're supposed to live your life until biologically cease to exist. And so will this have an impact on younger generations, say children or grandchildren, who choose this route? I mean, they used to call it assisted suicide. And so it's a question of how to make this about you taking your life.
Okay, so does assisted suicide or death with dignity lower the threshold for people who follow? And that's a question that's probably worth doing some research about. I'm not sure. I know I read an article recently about a professor who taught here with me at the medical school, who's now in Colorado. And he deals with suicidal patients like you would deal with somebody who has a terminal illness. So he doesn't automatically think that they should choose life. It's more like they have a choice. And he just wants to make sure that when they make that choice, they aren't in the depths of a treatable depression. And so he wants to work with them to make sure that they're making a decision that they're making from the healthiest, at a point in their lives that's healthiest as possible.
I that story.
It wasn't in a journal that I read it. It was in the newspaper, maybe the New York Times. And there are some people who've been chronically depressed and who've been struggling and who haven't, anything that we've done as professionals with treatment hasn't really made that much difference. And so for those people, I can imagine that this idea of having a dignified way to go might make sense.
My understanding at this point is to get a physician to prescribe a lethal dose of medication. You have to have a psychiatric evaluation, and you have to have an illness that is not treatable anymore. Yeah, it's a terminal condition. We actually had somebody in our church do this. We had ALS and knew where it was going, and really didn't want to spend time on a ventilator and not able to move and all of that, and chose to end. So to me, that's really different. When you have a terminal illness and you're no longer able to do anything meaningful in your life, then, I mean, I don't like the term suicide associated with that. I like the death of dignity. They're going to die in 1 to 3 months anyway. Why suffer? That could be a religious or philosophical. If that 3 months was going to do something wonderful for their family, or is it just going to use up resources and make everybody pretty miserable?
And our society.
Did you all hear what was just said by Marjorie?
Yeah, Marjorie has a nice, clear voice. And as I recall, the law says he had to be able to be ambulatory to administer it to himself. And he only had so much time before his hands would quit working. So that's why the decision was pushed up.
Well, our culture,
Okay, speak up, Bruce.
our culture doesn't accept that idea. Natives, on the other hand, looked at it. Some of the tribes, the older people, right, that felt like they weren't able to contribute anymore would go off and go. And it's it's an idea that's worth having. And the death with dignity is okay. Suicide on the other hand is like you. I mean, I look at suicide as a physically healthy, medically healthy person taking their life. And death with dignity is a different idea. That is, to me, but that's my opinion. There are other people who don't.
My wife has two friends who, both of whom stopped eating. One of the friends was a woman in her mid-70s who was still in pretty good health, but she noticed that she was beginning not to be able to remember. And she had a family history that was heavy with Alzheimer's. So she at some point decided, and she knew that if she waited too long, she wouldn't be able to do it. So she stopped eating and within 2 weeks died. The other woman was a woman I knew fairly well, but and was living one of the retirement homes in Northeast Heights, far Northeast Heights. And she had lost her husband, and she was in her 90s, and she was having increasing just difficulty getting around, and she decided that, it was time for her to go. And I was interested in the fact that she chose the time to go when my wife, who was a very good friend of hers, was on a trip.
Oh.
And I don't know whether she was doing that as a kindness to my wife or as a way to keep my wife from interfering with her doing it, even though my wife was sympathetic to her position and knew she was planning to do it. But I think there's a lot of situations like that. And I think the real shame is when somebody has a road to recovery, a way to health, and they're not using it either because their depression is so severe or because their impulsiveness keeps them from finding a way to do that. And one of the things about men versus women that I can't emphasize enough is the willingness to ask for help is really important. And I've always been willing to ask for help, so I can't personally relate to this as a person, but I've seen a lot of men who aren't, who feel like they just have to tough it out and work through it themselves. So.
Yeah, my brother.
Sadly, I think that's cultural.
Yes.
It's sad, but it's cultural. And when girls get together, they share their emotions, they cry, they laugh, and guys just don't share their emotions.
Some guys do and some guys don't. I don't know how many of you remember me 23 or 4 years ago when my first wife was dying of cancer. I was only too ready to share it. I was a mess. And I was
Would you
grateful.
like some coffee?
I work with a bunch of engineers and they would not,
Yeah,
and scientists, they just academics, they
probably
don't do that.
career choices that indicate that you're less likely to seek help of one sort or another than another as well.
I was just gonna say, in my brother's case, part of it also was, I am a competent male. I am more competent than any doctor could be. Because he had this, part of his image was being competent. And he was very, very competent. He was absolutely fantastic in his job. But it was a different, area. And the idea that somebody over here could be equally competent, but in a different area. That didn't happen.
Has that changed for him?
Yes, because he finally got on a medication that helped. And after about a year or so, he said, even the dogs like me more. Yeah, dude. Well, it took a while.
Side point to Ginny's point, one of the most interesting phenomena that I've encountered is something that we call projective identification. And what I mean by that is it's a person that projects something, and they do such a good job of it that the person they're projecting onto identifies with that projection. So one of the things that I noticed when I was practicing psychotherapy is I would be sitting in my office thinking I was sitting there the same way I had been sitting the hour before with a different patient. And all of a sudden I would be really angry or really sad. And it was often when I got to the point where I realized that when that happened, I was picking up a projection from the patient and expressing it. And it happened particularly when the patient was not saying I'm angry or I'm sad, but just feeling it. And sitting in the room feeling it, I was much more likely to pick it up and wonder, where did this come from? And then I would, once I knew where it was coming from, then I could start to address that. But similarly, you can project a sense of, I'm not likable. When you're depressed, that's one of the things that some people think, I'm not very likable. Nobody cares for me. Nobody thinks I'm worth it. And if you are good enough at projecting that and get other people to respond to you that way, it only reinforces that pattern and that cycle, making it harder to get out of the depression.
I know at the time our children were starting college, there was like a huge increase in suicides at Cornell. And then there was also like pockets of suicides at various high schools. And I was wondering if you could address that kind of, where there's a whole bunch occurring in one situation.
Yeah, Cornell was this famous bridge.
Is that where they're all jumping off?
Yeah.
So I know a couple of our friends, our son's friends, had gone to Cornell and packed up and came home. They said, I don't want to be here.
That's because of the winter.
Oh, no, because they were right there.
Yeah.
We need to remember our audience here on the.
Could you hear me, Dad?
I picked up about half, Barbara. They're depressed at Cornell. Is that what you said?
Increase in suicides at Cornell, like a lot of. And then.
Could it be photo period? I mean, that's up north, isn't it?
Oh, yeah. But it wasn't at Dartmouth, and it wasn't at Yale, and it wasn't at Harvard.
Yeah.
It was at Cornell.
Cornell. Wow.
Yeah, that relates to.
2000-ish to early 2000s.
That relates to what you brought up. That there can be epidemics. I remember I was bird watching in Point Barrow, whatever it's called now, in Inuit. And I noticed, because it's a long story, but because of the permafrost, the cemeteries weren't flat because the coffin in the ground would cause the ground to move. So it was hilly. And it turned out that was a place that the birds would hide out because they had some shelter. But wandering around the cemeteries with these two other bird watchers that I was with, we noticed that a lot of the people in the cemeteries were young. They died at a young age. And so I asked a native woman about that, and she said, oh, that just happened. She sort of shooed me away. But then I asked the woman who ran a restaurant there. She served hatch green chili, by the way. And she used to take baskets to families when there were deaths. And she said, oh, yes. She said, when one member of a family will commit suicide, other members will commit suicide. And it's a little bit like an infectious disease. And especially if both family members have some depression or some of the same issues operating. And certainly everybody going away to college. Going away to college is a big separation from your family. It brings up a lot of issues in terms of how to adjust and how to make the transition. And a lot of those people are depressed. And that's a And so it's not surprising to me that that would happen in an epidemic sort of way. Okay, one of the things that I feel like it's really important to make sure that I haven't finished this lecture without saying is that major affective disorder comes in several varieties. There's it's what they used to call manic depression. So there are people who have what we call bipolar 1, which means they have manic phases and depressed phases. Bipolar 2, where they have dramatic manic phases and subtler depressed phases. They're not as dramatically depressed, it's harder to recognize, but it's there. And when you see that, that's particularly important to pick up on, because those people in those depressed phases, in contrast to their manic phase where they're feeling really good, are more likely to commit suicide. Affective disorder of any sort, manic or depression, is associated more with suicide. And one of the reasons for that is because there's an interaction between bipolar disease and PTSD. And some of the time, the post-traumatic stress disorder is more affiliated with that disease because the disease can be highly genetic, and family members preceding that person have been manic or depressed and created trauma for the children. And now those children have inherited the same tendencies and also experienced that trauma that they got from growing up with a traumatized adult who was manic depressive. So it's a combination, and both bipolar and PTSD make people more likely to drink or use drugs. And using drugs and alcohol is a wonderful solution to anything that makes you feel bad if the alcohol and the drugs make you feel better. And it would be a perfect solution if they made you feel better permanently. But most often they make you feel better and then you feel worse again. And when you feel worse again, you can get fairly depressed and demoralized by the fact that you're sort of cycling in and out of that. So that's why picking up dual diagnoses is really important. That's why picking up affective disorder, major affective disorder, is really important, because there are treatments for both. And if people get those treatments, the treatments are medications and also activities that people do. For example, I worked with alcoholism as one of my subspecialties. I worked with post-traumatic stress disorder as another subspecialty. And I had a lot of people with affective disorder, bipolar and unipolar depressions as well. And so I had to deal with this on a regular basis. And once a person got into recovery for alcoholism, for example, there were all kinds of things that were integral to alcohol recovery that helped with depression. I was so impressed by Alcoholics Anonymous when I first started treating people that I decided I would go to 3 meetings back in 1980. So I went to 3 AA meetings. And I was only going to go to 3 so I could learn what Alcoholics Anonymous was all about. But after 2, I decided I would keep going because I was learning a lot about how to deal with life. From the chatter in the meeting, the talk and the discussion, and the 12 steps, which have a very functional, if you follow them, impact on people's lives. And so I learned a lot about how to treat addiction, but I also learned a lot about how to treat depression, how to treat mania, and how to treat post-traumatic stress disorder by attending those meetings. So I'm extremely grateful for that, and I was always grateful when patients who had one or the other of those problems would go to meetings and take advantage of that learning. Because there's nothing like hearing your peers share pieces of wisdom for you to pick it up. And here, and of course, in most AA meetings in those days, there was a majority of men, all who were trying to be tough and independent and autonomous, but they had given up and gotten help, and they were sharing their joint compiled wisdom with each other. And that really made a positive difference.
Are you familiar with the author Frederick Buechner? His
Yeah.
dad committed suicide. He's a great writer. He said the church should be like an AA meeting. That why can't church and worship, here I am, God. I'm your
I
child,
actually
and I'm
translated.
sinful.
I have a confession to make. I used to translate the language in the church service every Sunday into sort of an AA meeting for myself. It worked really well. I'm sort of a non-theist, so it made it easier for me to deal with.
Seemed like the AA meeting was an interesting venue where all these people, especially the men, who are standing aloof, you know, and suddenly they decide, big enough problem, like share this stuff. Everybody wants to at that point. And that it's somewhat learning to do a site.
It's also providing a community for people, so they're not isolated. Suicide is often committed in isolation. And there was a recent article in the Times, maybe 6 months ago, about how Africa, there's so, this particular country, I can't remember which one, there's so little mental health providers that, and there was women that were so depressed and death rates were going up, that they train hairdressers to talk.
Can you hear that?
And to identify people that had problems and to refer them to therapists, and that it really dropped the rates of depression and suicide. And the whole concept was that people live isolated lives and they don't have a sense of community or a friend to talk to or somebody to hear, and that you can, without huge medical training, you can still be intervene and help by being that good listener, by being that friend, by asking somebody to sit down and have a cup of coffee. You know, it's just showing interest in another person and to listen. That's a really important role.
Did you hear that?
I got about half of it. It's the hairdresser.
To be interveners in people with depression.
Mhm.
In a country in Africa that we no longer know the name of.
Wow. Interesting.
I read the same article, I can tell you. It's in Central Africa.
Okay, any other questions or comments? We're at the end of our time, so.
I was just gonna add, in Albuquerque specifically and in New Mexico in general, it is very difficult to get a therapist or even a program that will work with dual diagnosis. Because if you come at it from the mental health system and they say, oh, we won't deal with you until you're sober. And if you come at it from the alcohol side or substance abuse of any, they say, oh, gee, you're mentally ill, we can't handle you. And so trying to find people who will do dual diagnosis is very difficult.
That's a very good point. And on that point, next week, Jenny Routman will be teaching this class. She will be talking about non-use. Which is another,
On mental illness.
which is another support system that's very important and too few people use. So I would encourage you to come and hear Jenny's talk next week, given her comment as we end today.
I was not trying to say.
I know you, but I was.
Good work. Sound like a mouse. So can we just
What a
continue?
shameless pitch.
Appreciate that.
Hey, John, did you get in touch with
No,
Andrew about the April
Yeah.
dates?
not yet.
Okay, because he's talking about combining his with Earth Day, so he thought those dates.
You're scheduled all the way through into the middle of August. I got classes all the way through the middle of August.
Oh, so you can't put him in April?
No, definitely not.
Oh dear. Okay. Well, when would you like me to tell him?
Yeah, I can't.
When would you like me to tell him?
That's what's gonna spend it. I'm gonna suggest something around Earth Day.
So
I
you
think
want me to tell Andrew that we can't?
I'll send him an email this weekend.
Okay, great. Okay, thank you.
Right. Okay, bye, everybody.